Shukran. So thank you very much, distinguished chairpersons, and thank you once again to the Congress for inviting me to speak at this very informative and educational conference. It's also a pleasure to come back to Egypt and to see many familiar faces and good friends. And also thank you to Lundbeck, the pharmaceutical company, for sponsoring this session. I've been involved with Lundbeck for many years. Lundbeck are unusual for a pharmaceutical company in that they are exclusively devoted to the brain. And in psychiatry, they're focused on psychosis and mood disorders. And in neurology, they are focused on things like dementias and Parkinson's. And this is different from many other pharmaceutical companies which have left the brain and gone to other areas like oncology and cardiovascular medicine. So I'm very grateful to Lundbeck for their support over the years. Today we're going to be discussing the complexities of depression and anxiety, and very important for all clinicians, how we can improve treatment outcomes in the real world. So here's the agenda overview. This is the welcome and introduction. I will then be doing a 20-minute talk on depression and anxiety and talking about the consequences of comorbidity. Dr. Nala Nagy, your colleague here, our colleague, will be talking about the successful management of anxiety disorders, and she'll be including a case report, I think, where she goes through the practical management. We will then have a conclusion and question and answers, and we look forward to questions on these important topics. So without further ado, I will be starting my lecture now on depression and anxiety and the consequences of comorbidity. These are my disclosures. I'm employed at King's College London. I work in the Maudsley and Bethlehem hospitals. I am an editor of the Maudsley Guidelines. I run the Mood Disorders Service and the National Affective Disorder Service. I do work with pharmaceutical companies and indeed other companies. We've just published a trial in JAMA yesterday on probiotics in depression. And I've got grants from various institutions and governmental bodies. So a very important point to make is that psychiatric diagnoses may be unstable over time. So in Denmark, Sweden, and other Scandinavian countries, they have very good population-based health records. So for in Denmark, they can capture all of the 5 million or so people in Denmark, and they can look at their health over time. And this is a great facility. It explains why many psychiatric researchers are keen to collaborate with Danish colleagues. You can see here a relatively recent paper, a Danish population-based health register cohort study, and mental disorders were associated with an increased risk of all other mental disorders when adjusting for sex, age, and calendar time. And you can see here things such as substance abuse, mood disorders, neurotic disorders, personality disorders. There's a sway from one to the other. Now, some of this may be because of inaccurate clinical diagnosis at the beginning. We know, for example, that bipolar disorder can manifest as anxiety, depression, before unveiling as bipolar disorder, with an episode of mania or hypomania. But even with perfect diagnostic practice, this would still be so. We have a paper coming out in World Psychiatry, I think in October, which is being led by Professor Rudolf Uhr from Canada, who's one of our alumni from the Maudsley. And this is about the transdiagnostic risk in families. And if you have a family history of one severe mental disorder, say schizophrenia or bipolar, your risk of other mental disorders is also increased. So there's clearly transdiagnostic factors operating. So comorbidity within psychiatric disorders is pervasive, and the risk persists over time. Now, some academics find this messy and unsatisfactory and would like to somehow tidy it up. But to my mind, it is really the nature of psychiatric disorders, and we should take this on board. So, as I've said, comorbidity rates are high in psychiatry and transcend diagnostic domains. Lifetime prevalence of patients with 1, 2, and 3 psychiatric comorbidities, you can see here in the circles. 41% of patients with 3 psychiatric disorders meet the diagnostic criteria for a 4th disorder. 53% of patients with 2 psychiatric disorders meet the diagnostic criteria for a 3rd disorder. And 66%, or 2/3, of 1 psychiatric disorder meet the diagnostic criteria for a 2nd disorder. There's nothing particularly new about this. When I was a resident in psychiatry in the 1980s, a long time ago, we did a study looking at people diagnosed with borderline personality disorder, and we found that all of them satisfied the criteria for other personality disorders, and usually other illnesses like mood disorders or addictions and so on. So you can see that in terms of the psychiatric comorbidity within and without diagnostic domains, there's a particular overlap between anxiety and depression, but there's also an overlap with externalizing disorders and, of course, psychotic experiences. If you look at the genetic evidence, major depressive disorder, and I'll come on to this in a moment, is strongly linked, particularly to GAD, whereas bipolar disorder is most strongly linked to schizophrenia. Now, what about the possible mechanisms of the comorbidity of mood and anxiety disorder? So this could be by chance, but that's unlikely, and the statistics do not support this because it occurs more than one would expect by chance. The pathophysiological links, either the anxiety disorder predisposes to mood disorder or vice versa. Now, given the diagnostic hierarchy, where we look at things in terms of their importance, with organic disorders being the first thing to rule out, then psychotic, then mood, then anxiety, we would say that the diagnostic hierarchy would suggest the second possibility. And then we have higher order mechanisms, the role of genetics, the familial environment, and the fundamental disturbance in affect regulation. Now, GAD, generalized anxiety disorder, and major depressive disorder are very closely linked, but are overlapping and independent disorders. And this slide is very illustrative of this. It includes work from Philippe Gorwood, my good friend from Paris, but also Kenneth Kendler, who's done much work about the genetics of these disorders in the United States. So you can see that the shared genes are between 22 and 41%. The shared environmental factors are somewhat over a third, but there are both independent environmental and genetic factors. So although more than 70% of risk factors for MDD and GAD are shared, there are about 30% which aren't. Now, a word of caution about the genetics. we've made enormous strides in psychiatric genetics over the past 25 years. And my current institution at King's is doing fantastic work looking at the genetics. Most psychiatric disorders are polygenetic, with multiple genes contributing, and we summarize this in the polygenic risk scores. But even disorders where we are making huge advances, we have much to understand yet about the genetics. So just to summarize the comorbidity again, 37% of patients with major depression have a comorbid anxiety disorder. 32% of patients with an anxiety disorder have comorbid MDD. Over the course of a lifetime, the figure for lifetime comorbidity of an anxiety disorder and MDD is 70%, and some reports are even higher. And 48% of patients with lifetime MDD have an anxiety disorder. And you can see the lifetime comorbidity odds ratios on the far side, with major depressive disorder and an anxiety disorder, an odds ratio, in other words, the multiple that this is increased by, of 3.2. For MDD and GAD, 5.8. Now, OCD is no longer considered by many to be an anxiety disorder per se, but it's also a very common comorbidity for major depression, with an odds ratio of 4.8. MDD and panic disorder, 7.4. Social anxiety and specific phobias between 2.4 and 3.7. So the important point here, and this is a lovely paper by my friend from Belgium, Professor Koen de Niettemeyer. The important point is that anxiety and depression should be considered at the same time. And what Koen did here was look at probable case anxiety and probable case depression. And if you look, they're very often comorbid. So what is the clinical importance of anxiety and depression comorbidity? Now, the theme of this conference is about comorbidities and diagnosis, and I think that's something that speaks to the heart of clinical practice. So diagnosis in psychiatry is complex and challenging, but that's why we need psychiatrists to be good at it. One of the key messages is when you see an anxiety disorder, look for depression, and when you see depression, look for anxiety. Bearing in mind that you should also be aware of other disorders, such as bipolar in particular. You should always be aware of suicidality. I think we've seen a real change with this, where people are much more open to discussing suicidality. And I think that's really the first step to good clinical care. And when patients are not responding, particularly review polarity, whether there's any suggestion of bipolarity, including from the family history or previous episodes, and comorbidity. Now, depression with comorbid anxiety is associated with a significantly longer time to remission. And you can see here the time to first remission across baseline psychiatric status. The orange line is for depression with the best outcome. The blue line is anxiety with the intermediate outcome. And the top line is comorbid depression and anxiety. Note that these are large numbers, between 267 and 487 per group. So half of the patients diagnosed with depression achieve remission within 6 months, and half of those diagnosed with anxiety achieve remission within 16 months. But in comparison, less than half of the comorbid group achieved remission from both depression and anxiety over 24 months. So this speaks to the particular challenge of comorbidity. Now, I want to go through some of the clinical studies, and these are particularly focused on treatment. And this is a study from China, published in Neuropsychiatric Disease and Treatment. This is a journal that I used to be a co-editor of and publishes many good treatment studies. And there's many high-quality studies coming out of China now. This is a study of the efficacy and tolerability of escitalopram in the treatment of major depressive disorder with anxiety symptoms. It's what one might think of as a pragmatic trial, a 24-week open-label prospective study in a Chinese population. In terms of the patients and methods, they were adult patients of working age, 18 to 65, a current episode of major depressive disorder with anxiety symptoms. The Montgomery-Asperger scale was at least 22, so moderate to severe depression, and the Hamilton anxiety score was at least 14, again, significant depressive symptoms. Treatment was with escitalopram, beginning at 10 and flexibly dosed up to 20 by the end of week 2. This was dependent on there being a less than 20% decrease in the MADRS total score. I actually think flexible dosing studies like this are particularly valuable to the clinician. There's always an argument when we're designing trials about fixed dose versus flexible dose. Flexible dose, to my mind, is usually the better design. In terms of the outcome measures, the primary outcome was remission on both depression and anxiety scores, the MADRS score less than 10, the Hamilton less than 7. And of course, there were other secondary outcome measures, such as the response rate in MADRS on its own, the change in MADRS, HAM-D17, CGI, and so on, quality of life, and of course, safety. One of the areas in which pharmacotherapy studies are, to my mind, superior to other studies in psychiatry is in the methodology for capturing side effects. This is much better in drug studies compared to psychotherapy studies, where it's often assumed that there are no side effects, or even studies of devices. Excuse me. So, the result, escitalopram demonstrated high remission rates and significant improvements in depression and anxiety symptoms over 24 weeks. Now, some of you may be saying there's no placebo control, but remember, escitalopram has been very well shown to separate from placebo in previous studies. This is much more a study of how things are in the real world. And you can see the change in the MADRS and HAM-A from with the MADRS starting at 33, really quite a severely ill population, down to 6.5 over the course of 24 weeks. Similarly, the HAM-A score, again quite severely ill, 27.6, down to 6. So the change in the MADRS score was minus 26.8 points. Change in the HAM-A score was minus 21.6. Again, very impressive outcomes. And overall, just under 74% of patients treated with escitalopram achieved remission at week 24. Now, if you think back to the STAR-D data, of course, escitalopram wasn't available then, but this is not that dissimilar a design, and the results are much more impressive than the STAR-D treatments. In terms of the primary outcome, there was a significant improvement in symptoms of depression and anxiety, really regardless of the baseline, although there were different trajectories. So you can see here, firstly, in terms of the anxiety scores, difference in remission rates between patients with different baseline levels up to week 8, but then no difference after week 8. So the more severely ill patients caught up. And that is also true with the depression scores. And the significant difference in the remission rate week 24 versus week 8, you can see at week 8 it was 40%, and this built up to 73% over the 24 weeks. Now, this is a very busy slide, and I don't expect you to go through it all, but you can see in terms of all of the measures, anxiety, depression, somatic anxiety, psychic anxiety, the HAM-D17, sleep, CGI, and so on, they all were significantly better, apart from one CGI score, at week 24 compared to week 8. Now, in terms of the efficacy of the CGI, I favor the CGI. I think the CGI is a very good global measure of patients' functioning, severity of symptoms and response. At week 1, over 80% of patients were moderate to extremely ill, and then by week 24, just under 50% were normal or not ill. And the CGI-S score, the severity score, significantly reduced from baseline to week 24. Now, safety, we always think about safety with drugs, and I think this is appropriate, and I do think we should be applying the same methodology to other treatment studies. And of course, there can be treatment-emergent adverse events, or adverse events that occur during the trial which are not necessarily due to the drug. But you can see the treatment emergent adverse events were mostly mild to moderate in severity. Only 4.3% of patients discontinued due to these events, and 4 patients experienced serious treatment emergent events, but only 3 of these discontinued escitalopram. And you can see the treatment emergent adverse events are listed on the far side. None of these are particularly novel: headache, nasopharyngitis, nausea, dizziness, diarrhea, and so on. So in this study from China, dose escalation was adopted to improve the treatment response. Escitalopram 15 or 20 milligrams was an acceptable dose in 60.4% of patients. The 24-week escitalopram therapy demonstrated high remission rates with significant improvement in depression, anxiety, and overall quality of life in this group who are particularly difficult to treat. The degree of baseline anxiety had a similar effect on the treatment response across all subgroups, and escitalopram was effective and generally well tolerated in the long-term treatment of major depressive disorder associated with anxiety in Chinese patients. How does this compare with other studies? Well, this is a study from a few years back looking at escitalopram effects on anxiety in patients with MDD and compared with paroxetine. Many of you will remember that paroxetine is the SSRI which is thought by many to have the best anxiety profile in terms of helping anxiety. In this randomized double-blind fixed-dose study, you can see that the benefits of escitalopram were greater than those of paroxetine. And the dose of paroxetine was 40 milligrams. Again, a big study, over 200 in each group. And again, you can look at the patients with MDD treated with escitalopram with baseline anxiety. And you can see escitalopram and paroxetine with the complete remission rates being higher in the escitalopram group for both CGI and the MADRS. So to conclude, depression with comorbid anxiety is associated with a significantly longer time to remission. In STAR-D, which I think is still a very important benchmark, patients with anxious depression were less likely to achieve remission after antidepressant treatments than those with non-anxious depression. Remember, overall in STAR-D, the remission rate after 4 steps was only 2/3 of patients, whereas in the Chinese study I've just shown you, it was about 10% higher with 1 treatment. So the escitalopram 24-week therapy demonstrated higher remission rates with significant improvement in the symptoms of depression, anxiety, and overall quality of life. I think the emphasis on overall quality of life and functioning is extremely important, and this is what matters to our patients. And the descriptive analysis shows that generally escitalopram is more effective than other SSRIs in terms of rate, response, and withdrawal rate. So I'll stop there. Thank you for your attention, and we'll move on to the next speaker.